Cervical lateral flexion is an essential movement in the biomechanics of the neck and cervical spine. This movement allows the head to tilt to one side, facilitating everyday gestures such as directing the gaze, holding the phone between the shoulder and ear, or adjusting the head's posture in different positions. When the muscular synergy in this movement is adequate, the muscles work in coordination, allowing for smooth tilting without mobility restrictions. However, when there is an imbalance in muscle function, some muscles may overwork while others become inhibited. This not only limits the range of motion, but can also cause pain, muscle overloads, and postural compensations that affect the entire cervical and dorsal region. In this post, you will learn how to evaluate muscle activation and cervical lateral flexion, which are the key muscles in this movement, and how to identify altered activation patterns. By the way, if you want to improve the evaluation and treatment of cervical mobility in your patients, I have left a link in the video description for you to access all the information about the Endurance Electromedicine service. When a patient performs a lateral neck flexion to the right, for example, the muscles that are most activated are the right sternocleidomastoid, which is the main driver of the movement, with the greatest activation during the lateral inclination to the right. Secondly, the right scalene provides additional support to the sternocleidomastoid, increasing the range of motion. The third muscle is the right splenius. It assists in the slight inclination and rotation of the head, providing stability. The fourth is the right upper trapezius. It stabilizes and maintains the posture of the neck by supporting the movement. And the fifth muscles are the left sternocleidomastoid and scalens. They are minimally activated to stabilize the neck and prevent excessive inclination. Thus, the ideal muscular synergy in right lateral flexion. The right sternocleidomastoid more than the right scalene, more than the right splenius, more than the right upper trapezius, and more than the left sternocleidomastoid and scalene. If this synergy is maintained, cervical lateral flexion is performed efficiently and without overload. Here is an example of a patient with pain and limitations in lateral flexion to the right. In the graph, it is observed how the right upper trapezius is activated more than the right scalene, and this more than the right sternocleidomastoid. The alterations we have detected are an excess activation of the right upper trapezius, which generates unnecessary tension and contributes to the pain. A deficit in the activation of the right sternocleidomastoid, which reduces the patient's lateral inclination capacity, limiting their movement. Let's compare it with a normal pattern. Notice how here it is indeed the case that the right sternocleidomastoid activates more than the right scalene, more than the right upper trapezius, and more than the left sternocleidomastoid. What are the key differences between the patient with pain and a normal pattern? The healthy upper trapezius activates 3 times less than that of the patient with pain. The healthy right sternocleidomastoid activates 2 to 3 times more than that of the patient with pain. The increased activation of the upper trapezius and the lack of activation of the right sternocleidomastoid disrupt the normal muscle synergy, limiting movement and contributing to the onset of pain. So to conclude, how could you correct an altered synergy in cervical lateral flexion? To re-educate this pattern, it is essential to reduce the overactivation of the upper trapezius using relaxation and motor control techniques, increase the activation of the right sternocleidomastoid with specific exercises, use biofeedback, employ electromyography biofeedback to re-educate the muscle pattern, and ensure effective projection. See you in the next post.